So you want to rename it? It is coming as Zoom meeting invitation, IAPTCB
Yeah,
meeting.
that's how it comes. Okay, welcome everyone. And this is meeting number 2 or series number 2 of the Pac-Man series. Hand it over to Dr. Pawan to take it forward. Over to you, Pawan.
Yeah. Thank you. Thank you so much, RSV, the treasurer of IAPTCB, for starting the session. So welcome all for this Pac-Man series, the Superman series of Pediatric Acute Care Management series from Indian Academy of Pediatrics Twin Cities branch. So today we are going to have a very nice lecture on approach to newborn with CHD. So I welcome our faculty and also the academic coordinators and the course coordinator for this wonderful program. Dr. Nitin Chawla sir is the course coordinator who is working as a chief of pediatrics at Kim's Cuddles Gachibowli branch. And also the academic coordinator for this session, Dr. Sri Krishna sir, who is a professor and head of the Department of Pediatrics, Apollo Institute, Medical Sciences, Jubilee Hills. I request the course academic director, Dr. Sri Krishna sir, to give his initial remarks and hand over to the course director, Nitin Chawla sir.
Good afternoon, everyone. And last time, I hope most of you have enjoyed this session. This particular pediatric acute care management is a certificate course. And I expect many delegates have cleared their doubts last time. And it is even after the session also, we expect the same response. And this today particular topic is about newborn with congenital heart disease. For this, we have really eminent speakers, Dr. Sindhu Maru and Dr. Nageswara Garu. Of course, Dr. Nageswara don't require any particular introduction. Everyone knows of you. And I thank both of them to come and give their expert inputs. Let us, Dr.
Sir, remarks by President Dr. Sugnakar sir and Dr. Anil Sridhar sir, the Dynamic Secretary of IAPTCB. Sugnakar sir, the President IAPTCB.
Thank you, Pawan. I congratulate all the faculties, Dr. Sri Krishna, Dr. Nitin Chawla, and Dr. Pawan for their effortless service in this Pac-Man series. I hope this session, today is the second session and an interesting session. And main speaker is Dr. Nageshwar Rao and Dr. Sindhu, approach to the congenital heart disease. I think that Dr. Nageshwar Rao will take us through the journey of the congenital heart disease with his vast experience of over 30 years. I think all the delegates will benefit from this lecture, and I hope you enjoy the series in the upcoming features, upcoming series also. Thank you.
Yeah.
Sridhar.
Yeah. I'm Dr. Sridhar, Secretary of IAPTCB Hyderabad. I welcome you all for this Pac-Man Series 2. And the topic is very interesting. Really, it's a volatile subject. The topic is approach to a newborn with congenital heart disease. The first Pac-Man series was a very huge success. And this last 15 days back, we had conducted. And it was like visitors of YouTube and total people are around more than 1,000 people had seen the Pac-Man series first part. And I think in nationwide, it had increased to around 1,500. I am expecting this time 1,500 to 2,000. And the main concept vision is improving pediatric emergency care and the skills of the pediatric practitioners. This is the motto behind the Pac-Man. So all the best for the organizers, Nitin, Pawan, and Sri Krishna sir. And go ahead. All the best.
Thank you, sir. I think without wasting much time, we will start with presentation. Thank you, Dr. Sindhu and Nageshwara sir, for taking our time. And
please give a brief, orientation overview of our Pac-Man series, and then hand over to sir, because many new people have joined, so they need to understand what it is.
Sure. Thank you, sir. Thank you very much. I am available.
Yes, each one of us are doctor, but let us bring out the Superman in each one of us so that we can handle acute care in much better way. And that improved acute care at tier 2, tier 3 city is going to transform how critical care services in Tier 1 city will be shaped. With this notion in mind, to all the participants, I would like to welcome you for session 2 of PACMAN and Pediatric Acute Care Management with series second lecture. I'm proud to say that we have around 2050 registrations till now. And this session will be a guiding session by Nageshwara sir with presenter as Dr. Sindhu Maru, who is a neonatologist at KIMS Gachibowli. And we will be taking you on how to identify, what to do, and how to proceed. We'll start the session. Thank you, sir.
Good afternoon, everyone. I'm Dr. Sindhu, working as a consultant neonatologist at KIMS Gachibowli. Very happy to share with you all the seniors seeing here, at least sharing the screen, not the stage at least. So very happy. I think I'll start with a minimal or a basic thing and go in an advanced way. Am I audible, sir?
Yes, madam.
Yes, audible.
Yes, ma'am, you are audible. Make it full screen. Yeah, done, ma'am. Perfect, ma'am. Perfect. Go ahead.
Yes. So let me start with an case study. It's a preterm 33-weeker delivered by spontaneous vaginal delivery in view of PROM with a birth weight of 1.9 kg. Baby cried immediately after birth. Abgas were around 6 at 1 minute and 8 at 5 minutes. Baby had developed respiratory distress immediately after birth. Followed on examination, baby had cyanosis. Heart rate is 146 beats per minute. Respiratory rate is around 80 with an ST score of 5/6. Saturations were 87%. Bluish discoloration of lips, face, arms, and legs as cyanosis as mentioned. It's there. No obvious external congenital anomalies. In view of Silverman score of 5/6, delivery room CPAP has been started. And on examination of systemic examination, cardiac S1, S2 heard. Respiratory bilateral air entry is present but decreased. For abdomen is soft. CNS, baby is lethargic as expected in a preterm baby. Blood gas done at 1 hour of life was showing mixed acidosis with lactate of 1.8. And chest X-ray. If you see the chest X-ray of a preterm baby, where the which is showing there is a ground glass appearance almost. Both the lung fields are very minimal. Or this is after intubation. So both the lung fields are very minimal with the ground glass appearance, and reticular granular pattern is seen. So thinking in view of respiratory distress syndrome, so what could be the possibilities at this stage, that is clinically and after doing a few investigations like X-ray and ABG, possibilities could be respiratory distress syndrome, pneumonia, air leaks, pulmonary hyperplasia, pulmonary malformations, or pulmonary edema or venous hypertension, or suspecting congenital heart disease at the end. So primary, we think about most of the thing as the lung appears and as the baby appears more of respiratory distress, then we go more towards the respiratory pathology. So thinking in view of preterm with such kind of ground glass appearance of X-ray, we started on intubated and ventilated on SAMV with a 26/7 with high pressure requirement with 100% of FiO2. My first dose of surfactant was given within 2 hours of life as it has been transported from the outside. Surfactant is given within 2 hours of life. Followed, requirements of pressures was keep increasing. So escalated from the SIMV to HFO in view of high pressures. So then as we have moved on to HFO, even the respiratory distress didn't settle. So second dose of surfactant at 7 hours of life has been given. Still the baby saturations were not maintaining. Saturations were around 87 to 89. Dope was ruled out and hypoxia was persisting. PBG was showing persistent mixed acidosis. Then in view of high ventilator requirement and hypoxia, next day was like, it was Sunday and it took around 8 hours for me to get an echo done. So, and it was diagnosed to be an supracardiac obstructed TAPVC. With this kind of background, if you see, this is how we go in a normal pattern, thinking of how the respiratory pathology and cardiac pathology go hand in hand. So let me start with the incidence of congenital heart disease. The prevalence of congenital heart disease around 8 to 12 per 1,000 live birth. So rate coming around 9 per 1,000 live birth. Almost 1.35 million babies are born every year globally with a congenital heart disease. of which 25% are critical congenital heart disease. What is critical congenital heart disease? It's defined as a lesion requiring surgery or a catheter-based intervention in the first year of life. It could be a cyanotic or a cyanotic, which is requiring a surgery or a catheter-based intervention within first year of life. Then we call it as a critical congenital heart disease. Why did we label it as a critical congenital heart disease? So if we miss most of the newborn with the critical congenital heart disease are symptomatic, and or if not symptomatic, it can be identified after birth or before discharge, most of the babies. If we delay in a diagnosis, the mortality and morbidity will keep increasing it. And if the duct dependent lesions, the presentation may be vary, depends upon the PDA. So the timing of presentation varies with the underlying lesions, depends on PDA. If the closure of PDA can precipitate the clinical deterioration like severe metabolic, then they come in, then they present with a late onset after closing of PDA with a severe metabolic acidosis, cardiogenic shock, they present in a late format. So in a broad classification, if you take a congenital heart disease, we all know it's a like cyanotic heart disease, acyanotic heart disease, where cyanotic heart disease can be a decreased pulmonary blood flow or increased flow, whereas acyanotic heart disease can be left to right shunt, that is VSDs, ASD, AV, atrioventricular septal defect, PDA, and all obstructive lesions, that is aortic stenosis, pulmonary valve stenosis, coarctation of aorta or IAA. Next comes when we classify cyanotic heart disease, as I told you, increased pulmonary artery flow and normal or decreased pulmonary artery flow. Based on that, we again can be classified into dominant right ventricular, where is the defect? That is dominant right ventricular or dominant left ventricle. And so conditions of decreased pulmonary blood flow. What are the cyanotic heart disease? The decreased pulmonary blood flow are tetralogy of Fallot, VSD with PS. So most of the pathology or pathophysiology of heart disease, it is interlinked. It may not be a single condition like how TOF, where the 4 conditions are interlinked. Same way, it may not be a single condition where the underlying pathology existing. The God would have been created in that way for the compensating the remaining defects, like tricuspid atresia and PS, or single ventricle, or TGA with VSD for the compensation. So VSD is there. So ASD with PS. So cyanosis with increased blood flow, that is transposition physiology, TAPVC, common mixing lesions with unobstructed pulmonary flow, pulmonary atresia, VSD with several MAPACs. All these things can present with cyanosis with increased flow. So acyanotic congenital heart disease, as we know, that is normal or decreased pulmonary artery flow, that is originating from left heart sound, malformation originating from the right side of the heart, or increased pulmonary artery flow, that is left to right shunts. So how do they present? So as I told you, they can present immediately after birth, as we see in the index case, or they can present before discharge, like in a postmortem period where the baby will be in the postnatal ward, and we can pick up by the pulse oximetry screening, or it is immediately, or we can or it may be picked up suddenly with a decreased activity, lethargy, or a shock can be presented. So asymptomatic at birth until discharge from the hospital. So most of the early detection happens in the critical congenital heart disease. Prenatal screening will not detect all the congenital heart disease, and critical congenital heart disease can be detected by using a pulse oximetry. Is an effective way of screening. So American Academy of Pediatrics suggests to do screen for all the postnatal babies for the pulse oximetry screening. So I give more importance or initially part with the pulse oximetry screening, because it can almost, as I mentioned, 25% of 100% of CHDs, 25 babies will be like a critical congenital heart disease, and then if we miss in our initial period and they are ductal dependent lesions and they come back with us with a cardiogenic shock or something, then the treating would be much difficult. So early then the mortality and morbidity will be much more compared to early detection and early treatment. So pulse oximetry screening is one thing which should be all take on from this, at least from this talk, is that we need to screen for all the babies, all the postnatal babies with pulse oximetry screening. It's a very simple technique, that is, it is mainly useful for identifying the hypoxemia, which is not visible clinically. So it can also, it mainly difference what are we doing it is, that is pre and post ductal saturations, or we are monitoring it out. It's an easy technique, quick and safe method. The primary targets, what are the main conditions we have? As I told you, critical congenital heart disease are diseases which we are going to screen, or we are going to pick up. That they are pulmonary atresia, tetralogy of Fallot, HLHS, that is hypoplastic left heart syndrome, TAPVR or TAPVC, transposition of great arteries, tricuspid atresia, truncus arteriosus. It is done between 24 to 48 hours of age, or before discharge. If it is a normal delivery and the baby is getting discharged within 24 hours, just before discharge, we can do it. One sensor has to be kept at the palm of the right hand. The other sensor has to be kept at the feet. So screen is said to be negative if the saturations are less than 90% in right hand or foot, or if the screen is in doubtful, that is 90 to 95% in the right hand and foot, or the difference between the right hand and the foot is more than 3%. If it is in a doubtful, repeat after 1 hour. If the screen is said to be positive, that is more than 95% of the saturations in right hand or foot, the difference is less than 3%, then it is said to be positive. So the positive passed screen. So the passed screen we can omit there. If it is a failed screen, then do a further follow-up, further work. Or if it is in a doubtful, repeat after 1 hour. Even after the repeat after 1 hour, if it is doubtful, go ahead with the failed screen. Take it as a failed screen and do a further workup to see the diagnosis of the child. So what are the pros and cons for the pulse oximetry? The pros are it's an early detection and decreases the mortality, and it will detect the not only the congenital heart disease, it can easily pick up the early onset, early sepsis where the tachycardia can be picked up. So early symptoms of the sepsis can be picked up, and it is non-invasive and low harm, and it is very cost effective. Cons are if it is done within 24 hours, that is within 12 hours, the false positive results are more. And the after doing the false reassurance, if negative, if there is a screen is negative and we say that yes, the heart is good, there is no congenital heart disease, but they may come up later with their congenital heart disease. So the false reassurance, negative screen per se doesn't mean to be completely we are screening out all the congenital heart disease. Prenatal and staph anxiety and decreased sensitivity. The sensitivity of the test is 76%, whereas specificity that is 99.9%. So late presentation. So as I mentioned, early presentation, either they come with an early presentation, either they come, they present at the time of birth, or before discharge, they may present. Or late presentation, either they present with shock, cyanosis, tachypnea, pulmonary edema, or after later part of life where they present with feeding difficulties, that is suppressed cycle, decreased intake, failure to thrive, respiratory distress, that is fast breathing, persistent cough, central cyanosis or pallor. Cyanosis can be a central cyanosis or intermittent cyanosis. Whenever as we know, squatting position cyanosis, they present with certain complaints, or they have excessive irritability and poor weight gain, excessive sweat during feeding or sleep. That is what they're doing, that like how we have how the symptoms of like an angina, where they have excessive sweating during feeding or sleep, poor weight gain, decreased activity, or excessive sleeping. They may present with this kind of clinical manifestations. If they present with the above symptoms, how do we approach with each symptoms? So whenever we are starting with the suspecting of CHD, 5 questions we need to have in our brain. Number 1, is the patient is acyanotic or cyanotic? There comes some clarity. Where are we? What are we treating, and where are we going ahead? Next thing is then after knowing, we need to see is the pulmonary arterial blood flow is increased or not. How do we get it? No, we get by an X-ray also. Does the malformations originate in the left side of the heart or right side of the heart? By examination, we can know that. Which is a dominant ventricle? Is a pulmonary hypertension present or absent? With this, we come almost by the end. We come almost where broadly, at least, where are we heading towards? Which part of the in the classification? Where are we heading? Are we treating with a cyanotic? If it is an increased blood flow or decreased blood flow, are we treating acyanotic, obstructive lesions, or a shunting lesion? So starting with the history. So some patient came with certain kind of symptoms like shock or cyanosis or pulmonary edema or tachypnea. we have a suspect of congenital heart disease, then let's go in a traditional manner, that is history, general examination, examination of precordium, X-ray, ECG, echo. So history. History starts from the antenatal history and family history, and how is the child's weight gain, how is the feeding issues of the child, is the continuous feeding or there is a suppressed suck cycle, is an excessive sweating, frequent respiratory infections or exercise intolerance, if the child around 2 years of age, if the child is playing continuously. Taking a detailed history much help us. Like few of the antenatal history which we usually see is that is maternal rubella, where we see congenital rubella syndrome with PDA or peripheral pulmonary artery stenosis, ASD, lupus, that is heart blocks, maternal diabetes, TGA, VSD, and teratogenic drugs. Any history of teratogenic drugs we need to rule out. Next, here comes a slide with fetal echo. Do we get a fetal echo for all the mothers who is antenatal, all the antenatal mothers? No, we don't do it. Fetal echo, we just do a TIFA with a broad of as they see all the broad of all the organs, but not a per se fetal echo for all the babies. So whom all to be done with the fetal echo? When to do fetal echo is around 18 to 22 weeks. What are the indications of doing fetal echo is the first degree relative maternal history with the first degree relative of congenital heart disease, any metabolic conditions, infections like torch infections, mother would have affected within first trimester of torch infections, autoimmune disorders, teratogenic drug exposures. So we need to get a fetal echo done. In a fetal indications, increased nuchal translucency or nuchal thickness, hydrops, abnormal fetal screen on antenatal scan, abnormal ductus venosus waveform, abnormal fetal karyotyping in NIPT, major extracardiac anomalies, persistent bradycardia or tachycardia. So with this fetal echo we will do if the baby has been diagnosed with any kind of congenital heart disease antenatally by a fetal echo, they can intrauterинely they can transfer to a higher center or treat accordingly. So postnatally, how do they present? They may present with cyanosis, the first one of the symptom. So what is cyanosis? That is bluish discoloration of skin, mucous membrane caused by increased concentration of deoxygenated hemoglobin, that is more than 3 to 5 gram per dl. Cyanosis can be a peripheral cyanosis or a central cyanosis. So any baby present with a cyanosis, we do think about both cardiac conditions and pulmonary conditions. Not only cardiac and pulmonary, the other conditions like methimmunoglobinemia, hypothermia. If the cyanosis is only peripheral cyanosis, we think about hypothermia, polycythemia, and neonatal sepsis. So cardiac conditions like critical congenital heart disease. Whereas pulmonary conditions, parenchymal, airway, extensive lung compressions like pneumothorax, hypoventilations, CNS or neuromuscular diseases, sedation, TPHN, abnormal hemoglobin like methimmunoglobinemia, metabolic, as I told you, hypothermia, hypoglycemia, polycythemia, neonatal sepsis. These are the major causes of cyanosis. So, in congenital heart disease, what are the conditions where we see cyanosis? It's observed in non-ductal dependent lesions like TAPVC, TOF, TA as critical congenital heart disease, whichever I have mentioned earlier. And then differential cyanosis is seen in coagulation of aorta or IAA. So that is main important. The profound cyanosis depend on ductal dependent pulmonary circulation like critical PS. So the cyanosis would have been a minimal and then it become profound after the ductus would have been closed. So there is ductal dependent pulmonary circulation or ductal dependent upon systemic circulation. So cyanosis. So whether it is a respiratory onset or a cardiac onset based on three things. Number one, work of breathing. So work of breathing will be more in respiratory and less in cardiac. And cyanosis will be more on cardiac conditions than compared to the respiratory. Then we should go ahead with the hyperoxia test. What is hyperoxia test? Administration of what is hyperoxia test? Exposed to 100% of FiO2 for 5 to 10 minutes. The baby, we expose the baby to 100% of FiO2 for 5 to 10 minutes. Then take an ABG or SpO2, saturations or a PaO2. If the PaO2 is more than 100, most of the time it is a pulmonary etiology. If it is PaO2 is increases to less than 20 mm of Hg, then as it is not responding to oxygen, so it could be a PPHN or CCHD. So here comes cyanosis. Then think about doing hyperoxia test. Hyperoxia test, whether it is positive or a negative, If the patient is responding with the hyperoxia, then we are treating with the pulmonary condition. The patient is not responding, or PaO2 is not responding with a 100% of I5O2, then it is PPHN or CCHD. Then how do we differentiate PPHN and CCHD? Then next doing is hyperoxia, hyperventilation. That is, ventilate the child with 100% of FiO2 with respiratory rate of 100 to 150 beats per minute. Then if with the hyperventilation, if there is a PaO2 increases at around critical PaCO2 often less than 25 m of Hg, then PPHN. There is no increase in PaO2 even of despite of hyperventilation, then we think about critical congenital heart diseases. The PPHN could be a cause, could be anything. It could be a congenital heart disease or it could be respiratory, like RDS leading to PPHN. So it could be both, or MAS leading to PPHN. Next, so as in a simple format, central cyanosis, do hyperoxia test. If it is improved, then think about pulmonary pathology. If it is not improved, then go with hyperoxia, hyperventilation test. Improved, PPHN, not improved, echo or CCHD. Next symptom they present with is shock. That is, what is shock? That is decrease in the flow. So either in oxygenation or absorption. So when any patient present with a shock, that is like CFT delayed more than 3 seconds, BP is less than the percentiles, or heart rate is more than 160 for the baby within 6 days of life. So then we think about shock. So what kind of shock? If the baby, after getting an investigation, if there is a cardiomegaly and if there is a murmur, think about more towards the cardiogenic shock than compared to other kinds of shock. So it occurs most of the shock, what are the conditions congenital heart disease present with a shock are HLHs, like the left obstructive lesions, that is hypoplastic left heart syndrome, aortic stenosis, and IAA, where the left side of the heart will not able to pump it. So they present with that of the shock features. Next symptom will be respiratory distress. So they present with the respiratory distress, that is tachypnea and retractions, and mainly the difference should come with the pulmonary or a cardiac cause. So previously, as we discussed, it is hypoxemia, cardiac or pulmonary. Same thing, hypoxic test also you can do here with to differentiate between the cardiac and pulmonary. On cardiac, again difference, get an X-ray and see decreased pulmonary blood flow or normal pulmonary blood flow. They may present with a pulmonary edema. It occurs in obstructive TAP-AVC, pulmonary hemorrhage. Pulmonary edema can also come as a symptom like pulmonary in case of PDA, where there is a rapid fall in pulmonary vascular resistance leading to pulmonary hemorrhage. They may present with pulmonary edema. So with the symptoms, we can get some idea which system we are dealing with, and where are we dealing, what are we dealing with, like cyanotic or acyanotic heart disease. With an examinations, then further we comes down like which condition are we treating it out. So general physical examination. So cyanosis, if the child is having cyanosis, skin modeling. If the severe cardiac compromise is there, then severe cardiac compromise, then we can see the ashen gray color. When they come with 1.5 year with failure to thrive and all, they have this kind of ashen gray color with a severe pulmonary cardiovascular compromise. They may have a rapid breathing with tachypnea, retractions with using all axillary muscles, or on examination we can see about CFT, temperature, and see about the blood pressure monitoring. So then on a complete examination, never ever we should forget, even in a newborn examination or in an examination in diagnosing of the congenital heart disease or a respiratory, palpating the distal pulse, which is very, very important. It is femoral pulse. Though we write in the newborn examination or newborn case sheet, but most of the time we miss it doing of palpating the pulse of the femoral pulse. So that is very, very important, which is most of the time we could pick up easily the COAP by using palpation of the distal limbs. Next, after general examination, we go ahead with the cardiovascular examination. Cardiovascular examination start with heart rate, whether it is a normal heart rate or brady or tachycardia, that is more than 160 within 6 days, which we should think about. If the heart rate is more than 160, we should think about arrhythmias. And then starts with per se cardiovascular examination, that is precordial activity. Palpation ascertained when there is a heart is located on the left side of the chest. Dextrocardia is often associated with the most, if we are with the most of the time with the dextrocardia, then complex congenital heart disease, definitely most of the time it is associated. Dextrocardia and complex congenital heart disease. While palpating, we need to see ventricular impulse in the left parasternal area. So where is the heart? Where could we palpate the heart sounds? If it is a ventricular impulses on the left parasternal area, suggestive of right ventricular volume or pressure overload. If there is an increase in apical activity on the apical activity, then we go more towards of the left ventricular volume or a pressure overload. So left parasternal, we know left parasternal area, it's most of the time it is an right ventricle area, whereas apex more of the left ventricular area. If there is an impulse is more on the right ventricle, it will go towards the left right ventricle volume or a pressure overload, whereas left ventricle, if apical activity is seen more, it is left ventricular volume or pressure overload. Thrill, is there any thrill due to outflow tract obstruction or restrictive VSD? Then on auscultation, how is the S1 heart sound? Is there any splitting? And splitting is audible 80% of the normal. Normally, also we can see that splitting of the S2 splitting. Single S2 occurs in case of in aortic and pulmonary atresia, truncus arteriosus, PAH, and wide split occurs in case of ASDs and bundle branch blocks. And next, last, very, very important is murmur. So where do we see, what kind of murmurs we see? Two murmurs. One is innocent murmur. Most of us would have examined innocent murmurs on routine examination of the normal or preterm newborns, where there are innocent murmurs. Why do we see innocent murmurs? It occurs because of the pulmonary branch stenosis. That is the last pulmonary arterial branch stenosis where we get innocent murmurs. And how do we differentiate is there is a mild systolic high pitched murmurs like an ejection murmurs, and mostly it is heard in the pulmonary area, which is radiating to axilla and back, but mostly it's heard in the pulmonary area. Still murmur, it is also a kind of innocent murmur because of why is it heard? Because of the pulmonary valve leaflet vibration. Whereas there is a pulmonary valve in the lower side where there is the valve gets vibrated. We could see this still murmur. This is also a kind of innocent murmur. It's a low pitched vibratory murmur of 1 to 6. Systolic ejection murmur are usually best heard in the lower left sternal border and apex. So if the innocent murmur is there, so what is the next? The protocol for a baby with innocent murmur is, number 1 is review prior to discharge. Again, re-auscultate, again re-examine the baby before discharge. And before that, as we discussed priorly, do an pulse oximetry screening. Though we are not missing it out the critical congenital heart disease. So check for the postductal saturations. And if the postductal saturation is, if the pulse oximetry screening failed, go ahead with that echo and ECG. If the diagnosis of the innocent murmur confirmed, then then we found like before discharge, we found it's looking like an innocent murmur per se, definitely. Then review in 2 to 4 weeks. Then inform the parents, counsel the parents regarding the innocent murmur and thinking of innocent murmur. And if any symptoms like breathing difficulty, feeding difficulty, get back the baby. And if we have a doubt, if it is not an innocent murmur, get an echo done prior to discharge. But it is not compulsory to get an echo done for an innocent murmur if you are confident if it is an innocent murmur. But if you are doubtful, better to get it echoed before discharge. Pathological murmur. We know pathological murmurs are always associated with the structural heart disease. So when do we get an echo done is murmur intensity grade more than grade 3, harsh quality, pansystolic, loudest at the upper left and upper right sternal border, abnormal S2, absent or diminished femoral pulse or non-cardiac abnormalities are associated with congenital heart disease. So if there is a pathological murmur, no doubt, directly admit the child in the neonatal intensive care before getting an echo done priorly. First, admit in the neonatal intensive care unit, then go with the pulse oximetry screening. Then perform the full examination of the pulse of the lower limbs, perform the BP of the all the 4 limbs, then echo prior to discharge or echo compulsory for the pathological murmur. peripheral artery, if the child is having a pathological murmur, but the child is not, pulse oximeter screening is negative and all the 4 limbs BP are good, then echo can be postponed if the clinically stable child for the next visit, or if the symptoms doesn't there, then we can postpone the echo. But if not, definitely echo should be done prior to discharge. So peripheral arterial pulses should be examined, that is decrease or absent of lower extremities pulsations, that is femoral pulse or distal pulse. Then thinking about coagulation of aorta. So when do we say, in case of, if we need to see the BP for all the 4 limbs, is systolic of pressure more than 10 mm of He, higher in upper body compared to the lower body, then think about coagulation of aorta. So the examination with the pulse and the BP, both the things are necessary in examining the cardiovascular system of the baby. Next, parabdomen. So respiratory, cardiac. Next comes with the parabdomen. Hepatomegaly. Hepatomegaly is seen in case of coagulation, critical AS, and cardiomyopathy or infradiaphragmatic TAPVC. Even hepatomegaly is seen in, we usually see in pulmonary diseases when the liver is pushed down. If we hyperinflate the child, if the baby is on CPAP, and if we hyperinflate, then the liver will be pushed down, and then we feel it is like a hepatomegaly. Investigations. So after doing a distal complete examination, then we will go ahead with the investigations like ABG. The basic investigations first initially we do is ABG and X-ray. ABG. So how do we differentiate is, in case of an cardiac conditions, it is more of metabolic acidosis indicates that is cardiac shock or impending cardiac shock. If the PCO2 is elevated, most of the time it is a pulmonary disease going towards, we are treating towards the pulmonary than the cardiac. If it is a metabolic acidosis and with the features of shock, definitely we should have a back in mind, have that we are treating we may treat a congenital heart disease. So next, so as this is the hypoxic test which we have discussed priorly, that is, if the saturation is 21%, with a saturation of 100%, if the PaO2 is more than 150 or SpO2 is 100%, we are treating a pulmonary disease. Or if the PaO2 is not improved, that is less than 50 or saturations are less than 85, then we are treating the cardiac disease. So in cardiac disease, how do we differentiate between the parallel circulation mixing with decreased blood flow or restricted pulmonary blood flow is, in a without a restricted pulmonary blood flow where the PaO2 is less than 150. See, the oxygenation is happening, but not much as compared to the pulmonary disease that is less than 150, and saturations are 100%. Whereas in case of an completely cardiac disease like parallel circulation, PGA and all, where there is PaO2 is not at all responding with the 100% of FiO2. X-ray, which is a major role, early role playing in diagnosing of the congenital heart disease. That is what all things we need to see. Number 1, heart size and shape. Next, pulmonary vascular markings. Number 3 is situs of the aortic arch. I'm talking about mainly the cardiac pathology. So heart size. So is there any cardiomegaly or not? If there is an extreme cardiomegaly, where is it? Is the right ventricle is enlarging or left ventricle is enlarging? So how do we measure cardiomegaly? Draw a straight line in mid of the vertebrae. Take the maximum inverts of the chest in the right side and maximum inverts of the chest in the left side. A and B. These should be less than 50% of the total CTR, cardiothoracic ratio. If it is more than 50%, then we take it as a cardiomegaly. Next comes with the heart shape. So if there is an change in the cardiomegaly, if there is a cardiomegaly, then we need to see the heart shape. So based upon which ventricle get enlarged, and the shape of the heart will change. Like we see that in case of TOF, that is heterology of Fallot, where right ventricular hypertrophy is seen, we see a boot shape where the heart moves towards the downwards. Okay, downwards and posterior. So this time we can see it a boat shaped, where the TGA and all we can see egg on stream appearance by narrow mediastinal shadow produced by anterior posterior rather than the right to left relationships. TAPVC. Next, we need to see the pulmonary vascular markers. That is, either are we treating with oligemic lung fields or or plethoric lung fields. So if it is an oligemic lung fields where bronchiovascular markings are, how the bronchiovascular markings are seen, or in a plethoric lung fields, how the bronchiovascular markings are seen. So we can differentiate. Are we treating with a decreased pulmonary blood flow or a increased pulmonary blood flow? Next, situs of aortic arch. So usually the normal anatomy of the aortic arch is left-sided. See, if we see, this is the normal position of the aortic arch, where the arch of aorta is standing. It's the main bronchus. This is the trachea. Here that is it is divided into right and left main bronchus. So it is intended towards the left side of the trachea as it passes the main bronchus. Sorry. As it crosses the left main bronchus. So this comes in normal position. If the right aortic arch, we can see right aortic knuckle, and as in case of TOF and all, we see right side of the aortic knuckle. Next, ECG. So we look at the rate, rhythm, axis of the ECG, and any chamber enlargement or hypertrophy, and pericardial disease, ischemia or infarction with an electrolytic abnormalities like hyperkalemia. Next, finally, echo, where we know what are the indications of echo. As we previously got, only the murmur, that is pathological murmur, definitely we need to get an echo done. And innocent murmurs, which we are not sure that it's an innocent, we need to get an echo done. And failed hyperoxia test, thinking about congenital heart disease, hypoxemia, respiratory failure, except like suspecting of PPHN, and assessing of hemodynamically sick HSPDA, where there is pansystolic murmur with metabolic acidosis, with wide pulse pressure. Then we need to get an echo done, and cardiomegaly in X-ray. Then screening echo if there is an antenatal or family history of their congenital heart disease. These are the indications of echo. So after diagnosing and after thinking about we are treating of congenital heart disease. So when we start with the treatment part, general supportive, first we need to start with general supportive care. Supportive care, if the child is hemodynamically stable, okay. If not, intubate the child, maintain the vital signs, conduct the 12-lead ECG, check for any functionals, and fluids and inotrope should be started, and UVC and UVC should be placed. And if there is any acid-base balance should be seen. Metabolic hypoglycemia and hypocalcemia should be corrected. And if polycythemia, partial exchange to be done. So keep the main things, TAPBC in a form of TABC. We need to start with temperature maintaining with airway, breathing and circulation should be managed prior to treating the child. Next, specific congenital heart disease. So if you're thinking this is a ductal dependent lesion and this is a critical congenital heart disease of ductal dependent lesions, start
Maybe
with.
can we have some discussion here, or we'll complete?
Yes.
What is the story? Sri Krishna sir, or can we have discussion here, or we are completing it?
How many slides left, Dr. Sindhu?
Another 2 slides, sir.
2 slides.
Okay, then we can complete.
That's what we can complete it.
So specific congenital heart disease measures, then prostaglandins should be initiated depending upon the lesions. If you're thinking towards a ductal dependent lesion, no need to get an echo done prior to the starting of prostaglandin. If you have an idea of thinking this as it is a ductal dependent lesion by the previous investigation, start off the PGE1 with a 0.01 mics per kg per minute. The main complications is think about apneas, tachycardia and hypotension, and be prepared if the baby is having if the baby is on room air or not ventilated, be prepared for the intubation, keep ready for the intubation. And next thing is cardiac failure. If the baby is going towards a cardiac, came with a shock and going towards a cardiac failure, restrict the fluid intake, start with the diuretics of 1 to 2 mg per kg once or twice daily. And if it's a long-term medication like PDA causing cardiac failure, long-term oral furosemide can be started, and oral distillation with 15 mics per kg per dose. And start then with the maintenance dose. Main thing is maintaining the electrolytic imbalance is main important in when we start about the diuretics. And then accordingly we need to adjust our dose. So final and most important is transport. So any congenital heart disease, shifting to the tertiary cardiac center is very, very important. Shifting intrauterine is better than the extrauterine after diagnosing basically, and lagging our time 2 to 3 days, which is more important if it's in a critical congenital heart disease. So transporting the baby intrauterine would, if we know antenatally, would be much better than the postnatally. So when you're transporting the postnatally, keep the all the IV access, stabilize the child clinically at our center, then stabilize the then transport the baby. So intubate the baby if the baby is in a borderline saturations, intubate, ventilate the baby. If thinking about start a prostaglandin, even if you have a doubt, start a prostaglandin infusion, and then place the central lines, that is UVC or UVC, and make sure that baby is not in any shock. All the inotropes or vasopressin should be started. And the risk during the transport should be hemodynamically, the baby should be stable before transporting, or stabilize the baby, then shift the child for take the transport to have a better outcome, even to have a better outcomes at the transport center. Thank you.
So, can I speak?
Yes, yes.
Yes.
Thank you, Dr. Sindhu. Very nice
thank you.
presentation. And I request Dr. Nageswara sir to give his expert opinion and any additions or any suggestions.
Thank you very much, Dr. Sindhu. It's a very nice case, actually, perhaps. And you covered elaboratively a lot of clinical aspects of the congenital heart diseases. I thank you very much, Dr. Krishna sir. He has been involved in academics for many years. Dr. Shugnakar Reddy, Dr. Pavan, all these people are very academically oriented. Pertaining to this case, I think always a neonatologist, maybe you can just show the X-ray alone of this baby, or else you can exit the slides so
This
that we
baby-
can have a discussion.
Okay, sir. This
So,
baby,
yeah, X-ray alone is sufficient actually. So most of the times in your NICU, the commonest problem comes when you look at this kind of X-ray. The X-ray is showing, yeah. So the important thing is, if you look at the X-ray carefully, enlarge and see, you cannot define the heart. There is no heart here. Can anybody define the cardiac borders? There is no cardiac border. So entire chest is filled with, you can see, bilateral, symmetrical, reticular pattern with distantly seen air bronchogram. Normally, you will see the trachea. At the most, you will see the right bronchus and left bronchus. Here, what you can see is, you can see the terminal bronchus also, the third generation bronchus also, but you don't see the heart at all. So that suggests that it is a pulmonary edema. So classical examples for this kind of X-ray, when you don't see cardiac shadow, either you think about hyaline membrane disease, or you think about any kind of pulmonary edema which is produced by the heart obstruction to the systemic circulation, or in case of late cases after 72 hours of neonatal age, maybe group B streptococcal infection. So here, I think Dr. Sindhu and group managed very well, shifted the baby, immediately checked it, and then any neonatologist, they will give surfactant, and the second dose of surfactant, if they don't respond, then that is the time where you have to actually seriously think what kind of problem it is. So important aspects, either small size heart or heart shadow is not seen, or obscured cardiac shadow with a distantly seen air bronchogram and bilaterally symmetrical reticular pattern, very classically lacy pattern, suggestive of obstructive total anomalous pulmonary venous return. It can be infradiaphragmatic, or it can be supracardiac, or whatever it is. So what will happen? In the fetal life, the pulmonary veins only take 8% of the cardiac output by the combined cardiac output. So if there is obstruction, they develop a fetal pulmonary edema. Over the period of time, what will happen? The terminal pulmonary arteries will be arterialized. So it is not that expansal, it's arterialized. Then you will have this kind of fetal pulmonary edema, and they don't respond, they will have all these kind of problems. So I think that is a wonderful X-ray, Dr. Sindhu. Second point is what Dr. Sindhu has been telling, that saturations, cyanosis, and PO2. Any kind of PO2 lesser than 60 millimeters of mercury, millimeters, you have to consider cardiac problem. It can be increased pulmonary blood flow, it can be normal pulmonary blood flow like TGA, or reduced pulmonary blood flow. Saturation alone may not give information. Suppose you have TAPVR like this, you have umbilical vein, umbilical artery, or jugular vein. You take the venous sample. If the umbilical vein saturations are very high, that gives an idea that pulmonary veins are draining into the liver. That is called as infradiaphragmatic TAPVR. If your cannula is in the right atrium, again your saturations will be very high. In this subset, postductal saturations may be low, but your umbilical venous saturations will be high. So any disparity between umbilical vein and postductal saturations again gives a clue that you are dealing with obstructive TAPVR. So cyanosis, as we discussed elaboratively, classified into peaceful cyanosis. That means the baby is having severe cyanosis, no problem, no respiratory distress. Classical example of TGA, transposition of great vessel. Cyanosis with grunting. Grunting means, you know, positive end expiratory pressure. When you put on ventilation, you adjust the PEEP. So babies, they adopt to the respiratory physiological mechanism to produce a grunt. That means that they would like to clear the alveoli. So grunting respiration is basically a physiological means of PEEP. Whenever there is a cyanosis and grunting, you should think that there is obstructive pulmonary venous return or ventricular dysfunction, critical aortic stenosis, or coarctation of aorta. This is second one. Third one is cyanosis with respiratory distress, acidotic breathing, respiratory distress. This is classically seen in duct-dependent pulmonary circulation, where the blood is not going to lungs. Lungs are all black. There is no vascularity. So oligemic lung fields will be there. The fourth one is mild cyanosis with respiratory distress, typically a truncus arteriosus or double outlet right ventricle with increased pulmonary blood flow, or single ventricle with. So you have to classify into peaceful cyanosis, cyanosis with grunting, cyanosis with heart failure, and cyanosis with respiratory distress or acidotic type of breathing. That's a wonderfully she presented very well. Here, you are all doing functional echo nowadays. Everybody is doing functional echo to check the LV function, IVC collapsibility, and how much of cardiac output is going. So if you extend your transducer, you can off that, you can stop your sharing.
Okay.
So that others can see the pictures. We don't have pictures, but we all can see each other.
Yes.
So when we do functional echo, I'm sure Dr. Sindhu is doing a functional echo. If you extend your a 4-chamber to outflow view, normally you will have aorta comes like this, pulmonary artery goes like this, great vessel crossover. When you see the vessels are parallel, that is a TGA. You can easily diagnose. I don't think you need a pediatric cardiologist for that. there are only 3 important cardiac conditions which often missed by the neonatologist or any of the cardiologists. I won't only confine to neonatologist, anybody. Number 1 is TGA. Number 2 is coarctation of aorta. Number 3 is the TAPVR. So if you master these 3 in functional echo, you are going to diagnose more than 95% of congenital heart disease. So each one has got its own role. Like TJ is important in the NICU because you want to start prostaglandin, you want to stabilize the baby, and the treatment is 100% accurately. Arterial switch operation can be done by tilting your probe and demonstrating the crossover. Whereas for coarctation, apart from your preductal, postductal saturation, I want to tell one important clue. You fix the pulse oximeter plethysmography. The plethysmography will show you a sinusoidal wave pattern. You have steep up slope and down slope. When you have a coarctation, the postductal pulse oximeter will not give you plethysmography. It will be either blunted or very much delayed descending limb will be there. So you connect 2 pulse oximeters, right upper limb and lower limb. Then you see the pulse oximeter plethysmography differentiation. You are almost sure that there is some kind of coarctation is there. For that, you have to extend the neck and put a transducer. You will be able to see. The most difficult thing is TAPVR. Even best of the hands. Even I remember 10 years back, we took our own opinion of TAPVR. The important clue is any kind of clinical disproportionate symptoms to the ABG and chest X-ray, which you have shown very nicely. The chest X-ray showing no heart, no, you can't define cardiomegaly and all, bilateral symmetrical reticular pattern, pulmonary venous hypertension, and ABG is showing a PO2 of around 45. These 2 things in the presence of, when you give surfactant, even you increase the PEEP, you increase the FiO2, ventilatory settings will not be increased, then you should have a strong suspicion that we are missing the TAPVR. So then you have to establish the diagnosis. I think these clinical points probably we can add. Otherwise, it is a very great case to discuss much more from the critical care point of view, either in NICU or PACU. Thank you very much.
Sir, small doubt, sir.
Yeah, tell me that.
Sir, in case of pulse oximetry screening, which we routinely do, sir, should we do it simultaneously? If we're not doing simultaneously, we are doing one after the other links. Are we going to get any false negative or false positive results, sir?
So pulse oximeter screening for 2 things. One is saturations. Second is plethysmography. Plethysmography screening may not be useful in the beginning, only when they present with a shock or symptoms. When you want to diagnose that is a coarctation of aorta, it is useful. Whereas routine pulse oximeter screening lesser than 92%, if I am correct, nowadays above 92 is considered as a normal on day 3 up to day 5, I think. I don't know IAP guidelines, American Academy of Pediatric guidelines, but lesser than 92, certainly it is going to be dangerous. So you have to do. So what they recommend is you have to palpate the femoral arteries. So IAP advises to palpate the femoral arteries as a screening, routine screening pre-discharge from the NICU. But when baby presents, I think we have to check the pulse oximetry plethysmography that time. As a routine screening, I don't think, and there are no studies also to quote. It's only experience based, I am telling.
Thank you, sir.
Thank you. Sir, Sri Krishna, sir.
Here, do you recommend a routine 2D echo for all patients admitted with distress in NICU? Many times we see, most of the times we think about respiratory aspects. Only when there is no significant murmur and when there is no response to our respiratory care, then only most of us are thinking about going for 2D echo. But is it good to start in the beginning itself for to go for this?
Sir, nowadays,
If you go in that way, what percentage of cases you will get of total respiratory distress cases? What percentage of success? Because they getting investigation that to bedside in NICU, not always possible for many centers.
absolutely correct. Your points are very well, sir. If I take the natural history of pediatric cardiologist doing echo in the last 20 years, when we started, we were doing only complex congenital heart diseases. Now we are doing 20% are normal. We are doing 20% normal. So what is happening? Many of these babies, either cesarean section incidence is increased or preterm, late preterm babies incidence is increased. In those babies, ductus venosus is not getting closed. And PD also is not getting closed. So there are other causes. Transitional circulation itself is causing respiratory distress. But if an intensivist feels that it is a disproportionate to the degree of whatever you are thinking, like a high heart rate, low saturations or PO2, radiologically, is there any abnormality? Then those cases you should go for the echocardiogram beyond functional echo. The reason for that, number one, what Dr. Sindhu said, all the clinical examination, it's very good. But when you apply to the neonates, it is technically very much demanding because you won't be able to appreciate P2 loudness.
Yes.
Already there is a neonatal PVR is high and their heart rate is high. All neonates at one point of time, there will be some murmur because of the small TR, branch PS stenosis, that is physiological and all. So I think still it is a judgment by the neonatologist or pediatric intensive care person, any disproportionate amount. I think your NICU cases close to 20% will go for the echocardiogram.
Because many times we keep, as a pediatric intensivist, we keep that as a second option, not as a routine thing. But
Yes,
later
sir.
we feel that too when the patient is very sick, then we think that probably we would have done much earlier and detected and initiated if at all any treatment is there. This is the problem really. And otherwise, most of the times in the first 3 days, murmurs also we take that as a routine. That is a problem. Okay, these murmurs are common. We'll think if the patient is worsening. This sort of attitude is there among the pediatricians who are handling newborn babies.
But as per the NADA's criteria, the old books of NADA's, it is mentioned, any degree of murmur beyond grade 3 or cardiomegaly more than 0.6 or presence of diastolic murmur. If you appreciate diastolic murmur, absolutely we have to rule out because there is a heart disease. Because there is no functional diastolic murmur described in neonates. Diastolic murmur means it's a pathological. Systolic murmur beyond grade 3 is a pathological. So cardiomegaly and murmur, any degree of murmur, again it is a pathological entity we should discuss. So, but still, I agree with you that we all had one episode of one problem in life. Like we might have missed TAPVR, we did not see coarctation. So that incidence will make us to bring down our threshold, and then we advise the echocardiogram. It is quite normal in the West also. Typically, what is happening in Kawasaki disease, for an example, earlier we were going all by criteria. Now, entire Hyderabad is over-treating Kawasaki by 20%. That is, we are following the West. West, it is already there. We are also doing that. So, it is quite natural when the science advances, when we want to really don't miss any diagnosis.
That is the issue. Little over-treating may be always better than under-treating and not thinking about the disease at all and making the patient worse. That is. Thank you, really, thank you very much, Nageshwara garu, and even Dr. Sindhu. Dr. Nitin, do you invite some questions anywhere?
No, sir, not yet. Not in this session, sir.
Okay, you want to include the Dr. Sindhu and Nageshwara in the group so that they will answer later any questions in
Yes,
the
sir.
WhatsApp group?
Yes, sir.
Okay.
Sir, so from now on, I will add Sindhu, Dr. Sindhu in the group, and if Nageshwar sir will be joining the group as a guest faculty to take question or to give further point of guidance, then it will be great for all the participants.
But I request Nitin, it should be only 1 week.
Yes, sir.
You
Yes, sir.
don't trouble them for more than 1 week.
No, sir, I'll invite Nageshwar sir only for few days, and then he will
Sure,
leave.
Nitin. Nitin,
Nageshwar,
nice to see you
actually,
and I hear you.
Yeah.
Sure, definitely I'll participate.
Because it is seen by almost 2,000 people by YouTube, and they are
Yes,
the
sir.
people, most of the PGs are included there, and they
Yes,
will
sir.
have questions. So
Yes,
Dr.
sir.
Nitin has taken the pains of making them WhatsApp group along with them. So there will be a good number of questions also from them. So I request Dr. Sindhu and Nageshwara garu, just bear for 1 week,
Yes.
time. They
Absolutely fine, sir. It's a
question
pleasure.
answers they'll put and just answer them. After that, it's up to you.
It's up to you,
Sure,
sir.
sir. Sure.
Thank you, sir.
Okay, sir.
Yeah,
Thank
it's
you.
really interesting to know, sir. Actually, 2,100 people, that is never happened. Finance group, there are 1,700 people have joined, but this is the highest. It is broken the record actually.
Yes.
So we have to
My
start
God.
third WhatsApp group. Yeah.
Okay.
Sure, sir.
Pawan, closing.
Sir. Yeah. Thank you, sir. Thank you, Sindhumar ma'am, that for that elaborative and very lucid talk on approach to newborn with CHD. And I think deep gratitude from the IAPTCB to Dr. Nageshwar Rao sir for moderating session so nicely and sharing your vast experience here. As a students from the student days, we know how you passionately teach students and all. That is being reflected. It's very fortunate moment for me and sir also. I think we are really learned a lot from you, sir. We need more engagement with you. Please join us in the WhatsApp group also, sir. So thank you, Nitin sir, the course director, for planning and executing these wonderful sessions, and our academic director Krishna Surampuri sir for conducting this so smoothly. Thank you so much. Thank you IAPTCB for making it a big hit. Thank you, sir.
Thank you. Thank you. Thank you.
Thank you very much. Thank you.
Thank you, sir.